It's really a pleasure and honor to be here today. Thank you so much for having me. Kidney cancer is really a problem for us that we have dedicated our time and resources for more than 10 years, and this is something I really want to share end-to-end, the progress we have made, and the questions remaining, and the challenge that we have. There's really one goal from this talk that I want to give you, is really to empower you as the theme of the meeting, that we will not rest until we find the answers for the cure. So these are my disclosures. I want to highlight one and very important one, which was the Kidney Cancer Association Young Investigator Award, which was actually the seed funding for majority of the work, and then continue with other resources from different organizations and companies. So first, when I first started my PhD training, I was puzzling inside a kidney cancer problem, basically with the questions that has been coming to what I was assigned to answer about the signaling mechanism, etc. When I started the fellowship training, it was August 2019. I was not sure about that, whether I will continue working on a kidney cancer or something else. And my mentor, Dr. Eric Jonasz, at that time, said something good that, well, go to the clinic, find a problem that no one else has made a deep dive until now. So you will build really a connection to that problem, and you will be obsessed for the rest of your time to solve it. And that's what happened. So I was in the clinics looking through the patients and seeing patients. And this was the one actually strike me at that time, is it was a study. In fact, at that time, avelumab was not approved, and it was a regimen for a first-line treatment that was tested in a Javelin renal study. So the patient was enrolled to the study and had lung metastasis and had an excellent response to avelumab regimen. And then when I see the patient, the next line of the story was, I had a severe headache and seizure, and I went to the emergency room. And then it really showed us that, wow, a surprise. So we were expecting you continue having a response, but there is a dilemma here. There's a dichotomy in the response. Now it looks like the patient developed a brain metastasis. So this observation made us to ask this question: why the disease is behaving different in one organ to the other? Is there any reason that the immunotherapy didn't work in the brain metastasis, or is there any other way we can make it more effective? So to follow up on this observation, we reached out to the company who was running the study and had the data, Pfizer at that time, and they thankfully shared the findings with us, and I'm going to highlight the key points there. The upper Kaplan-Meier curves is showing the general population who were enrolled to the study, and the paper was published in New England Journal of Medicine, showing that in avelumab arm, it's significantly better than the sunitinib, and the median progression-free survival was measured as 13.8 months. The bottom Kaplan-Meier curves showing there was 23 patients who had treated, not untreated, brain metastasis, who had basically stereotactic radiation and then enrolled to the study. And as you could see, we don't see a significant difference between the sunitinib and avelumab in that cohort. Of course, the study was not designed to answer that question, so that might be a statistical challenge. But most strikingly, what we see is the patients who had brain metastasis had median progression-free survival of 4.9 months after stereotactic radiation, followed by systemic drug, which is basically 3 times less than the general population, which is really showing that this is an aggressive nature of the disease systemically that we need to define this problem and tackle. The follow-up study was from the Checkmate 214, which is showing that not only the brain metastasis patients not immediately responding to the immunotherapy, brain metastasis is the most significant, most common site of the disease that is appearing in someone who is progressing. When we look at the numbers, 28% of the patients who developed progressive disease had brain metastasis in Checkmate 214 study after the Nivo-IP treatment. So this was another evidence convincing us that, yes, we are evolving the field, immunotherapy is helping for other sites of the disease, but there is something happening in the brain that we need to figure this out. And a follow-up study from the multi-cohort IMDC very nicely showed that if you stratify the patients based on their site of the disease, pancreas or lung or kidney or lymph nodes or brain is one of the most poor prognostic features to have the disease. And when you look at the median survival of those patients, as in this study, this is an international multi-cohort study, 16.5 months overall survival. So that's really pointing the fact that we need to do a better job. So as the field was shifting from the TKIs to the IOs, then we decided to work with our global collaborators through the International Kidney Cancer Coalition to define what should be the approach for kidney cancer in this era with growing knowledge of the brain metastasis. Now, there is a major challenge here that none of these phase 3 studies, even the ones that are currently active, allows the patients who has active brain metastasis to enroll to the study. So that's a primary challenge for the field, that patients are excluded if they have a brain metastasis. FDA provided a guidance that this needs to change. We should allow with some measures, and hopefully that's going to affect as we evolve in the next stage of the phase 3 studies. So this was an algorithm that was developed. Now it's available, published. This is 26 institutions representing 6 countries from 44 investigators, including the neurosurgeons, radiation oncologists, neurologists, that we put our heads together to look at this. Even though we were trying to organize this to answer a question, as a medical oncologist, it really, I would say, hurt me a little bit to see that, wow, the systemic treatment is really a small line here. Well, maybe if there's a punctured lesion and if it's not really in an eloquent area, well, consider systemic treatment. And what would we would offer to patients' brain metastasis otherwise is stereotactic radiation and surgery. So these are great tools, as we learned today with our colleagues, that are helping to control the active disease. However, the challenge there is stereotactic radiation is so well precise treatment to the active lesion, it almost doesn't do anything else to the other sides of the brain tissue where there is a risk of the new brain metastasis development. So what that leads to the point that we need better systemic drugs that will help to prevent the showering of the brain metastasis to the brain from a systemic disease. And this led to the study, which was actually precisely funded by the Kidney Cancer Association Young Investigator Award at that time. And this was another challenge at that time. We realized that at MD Anderson, we were able to collect only 30 brain metastasis craniotomy tissues that was resected. And this was not enough number for us really to answer big questions given the small cohort. Then we reached out to our collaborators from my alma mater back in Turkey, Hacettepe and Emory. Thankfully, they shared their 30-year repository of the tissue cohorts, and we eventually put together several studies, which I will be showing one of these studies highlights in today's presentation. Together, there was 72 tissues. 14 of them were frozen tissues that we were able to apply cutting-edge technologies, which is including single nucleus. Basically, as you see, each dot here is one cell, and we are able to sequence one cell at a time to give us an idea what is the profile of that cell. We ended up profiling near 200,000 cells and defining 9 major types of the cells, 39 minor clusters, helping us to really to say that, yes, what is different here, and can we look at the differences across different organs and identify what makes brain metastasis more immunosuppressive. Later, we also validated some of these findings with COSMIC's spatial transcriptomics technology, which is giving us ability to look under a microscope, cell by cell, with diverse features of the profiles that are existing. So I want to give a big highlight that this study first showed us the one major information, that neuronal glial cells are infiltrating the tumor. It doesn't make sense. Well, actually, brain is the home for neurons. So tumor is infiltrating the neuronal area, and where it allows the tumor to come up with new behavior. Why it's important, in fact, during the last 2 months, 2 Nature papers elucidated more mechanisms related to the neuronal to tumor crosstalk, so that this helps us really to understand this mechanism more closely. So we were able to define 2 characteristics, basically the neuronal cell oligodendroglioside, and as you could see, the patients with brain samples, extracranial versus kidney samples. And then we validated with the protein staining, not at the transcriptomic level only, showing that NUN is a marker for neurons. And it looks like, and the red is the CA9, the tumor cells. It looks like they're basically created a hub together and living together. And not only that, it's not present in the primary kidney. So the disease evolved and changed based on the new environment characteristics. When we take a closer look at here, we realize that it's not only that they are together with the neurons, the cancer cells, which are the red circles, the membrane marker, also start expressing neuronal marker, as you could see here, which is basically defining the neurogenic transdifferentiation of kidney cancer. This is a well-defined phenomenon that has been described in prostate cancer. That's basically speaking to the aggressive variant of the prostate cancer that behaves not responding to the treatments and progresses fast. Similarly, the small cell lung cancer and others, but this was the first study showing and helping us to define that the same phenomenon is also happening in kidney cancer, and we need to figure out how to make the neurons not to talk to the tumors and not make them to behave differently in that environment. So then we run an algorithm including 11,000 ligand receptor interaction. Basically, these are the words, language that the cells use to each other to speak in that tumor microenvironment, and that help us to show that these purple tracks, highways, are the neuronal signals. Neuronal cells are obviously connected with each other, connected to the tumor cells, B cells, and macrophages and T cells. So they are basically communicating with every cell in that tumor microenvironment, trying to make them to behave differently. And why is that? Because brain by nature is a protected organ. Brain doesn't want to have the new infiltrated cells coming there and changing their behavior. So it's more philosophy that how we have been created to protect the brain as much as possible from infection, inflammation, and all other processes. And this is not existing in kidney tumor. So basically, even though the title of the disease is kidney cancer, we are dealing with something completely different. So then we look at this. Okay, is there any, I would say, low-hanging fruit targets on these communication signals that we can convince anyone to help us to test these new drugs? We took a closer look at the neuronal to tumor cells communication, and we identify FGFR4, MET, and FGFR2 signaling. So FGFR2 signaling is important for the neuronal maintenance, and neuron to tumor cell crosstalk has two proliferative signals, FGFR4 and MET, which I will come back to those signals in the next few slides. Beyond that, the spatial technology also helps us to see that the tumor cells are also behaving very different in the brain microenvironment as they have been influenced by the neuronal cell infiltration. So what do we show here is this serum amyloid A1 is usually secreted by liver when someone has fever and inflammation, giving an alarm signal to the body that we need help, there is something wrong going on in the body, infection or inflammation. The tumor cells in brain metastasis expressing that with that highly inflamed nature. And it is communicating with the toll-like receptor 2 on the tumor cells, on the macrophages, which is initially serving to bring more immune cells, but eventually creating a chaos. So what do we see here is the yellow cells are the tumor cells expressing red serum amyloid A1, communicating the neighborhood of the macrophages, which is expressing the purple toll-like receptor 2, that eventually making them behave more immunosuppressive than supportive. Now, this also leads to the next point, help us to see that it's not only the tumor cells, neuronal cells, macrophages, the whole cellular dynamic of the brain metastasis has changed. We were able to see less proliferating, which are our basically fighting soldiers, proliferating cytotoxic T lymphocytes in brain metastasis. These are basically the police guards that identifying the dendritic cells and monocytes, saying that there's a problem, we need to define it and attack it. There are less antigen-presenting cells in the brain microenvironment, and what we have is B cells without really well-trained memory capabilities, only able to create antibodies with their prior knowledge, but not trained in that environment. So I show you some exciting science, but as a clinician on a daily basis, seeing patients in the clinic, I always try to look from the perspective that, is there anything we can translate from this coding to the clinic to make sure that we are able to save lives? These studies led to the first clinical trial, which is targeting the neuron to tumor crosstalk, which is FGFR4 signaling, with lenvatinib. So it's not a surprise, and it was easy for us to convince the related parties at that time that lenvatinib has been known to target FGFR4, but that was not a high yield for the kidney cancer until this time. Now, this is going to be a multi-center study, enrolling 40 patients, testing a standard of care. So when we proposed this study, it was not FDA-approved regimen. Thankfully, now it's FDA-approved, so it will help us to enroll faster and bring the information to the sunlight that are we able to protect the brain metastasis development if we start this regimen. The good thing is we don't need to wait for the trial data since the regimen is already approved. So we start using it. And I'm showing you one example of our patients who we took care here at OSU. And I want to really highlight an important thing here. The brain metastasis is a multidisciplinary problem. We cannot be one person fighting and solving that. And I'm very grateful that we have that wonderful urologists, radiation oncologists, and neurosurgeons that we can basically text each other, connect, and solve these puzzles together. So this was a patient. In fact, he had actually a webinar in a public domain as well, that first time diagnosed with while playing a golf with seizure. No history of a kidney cancer before that. And ended up going to the emergency room, there's something in your brain. And the patient had a resection and identified that, wow, there is a kidney, this looks like a kidney cancer. and then was diagnosed with a renal cell carcinoma. So the patient was started on pembrolizumab lenvatinib treatment. I quoted you the number about the overall survival data from the multicenter study, 1.6 months, 16 months. And now, thankfully, our patient is doing well with this regimen that recently progressed after 4 years on staying in the same regimen. So I believe that this example really helps us to see that this regimen has a potential to prevent, but still it's not enough. We need to do a better job to find the next line of agent. And the next study that was funded actually the last month by Exelixis, which will be testing one of the new drugs in the horizon, zanzalintinib, which is going to be for patients who has active brain metastasis. So to make this more practical, in this study, we will not allow the patients to have stereotactic radiation. Basically, we will discuss with the radiation oncologist if the lesion size is too small enough that we can monitor under a systemic drug, that eventually we will need less number of patients so that it will allow that we will be able to provide every brain metastasis patient, since has been excluded from all other major studies, we can bring them a new space for the novel drugs to be tested. And now actively we are discussing with other companies to boost this regimen in adding other drugs to make this combination more effective. So what I describe here is brain metastasis is a kidney cancer, but a different kind of. And what we realize from the growing literature that there might be a need for paradigm shift in overall cancer-directed care. As of now, we treat kidney cancer as kidney cancer, breast cancer as breast cancer, lung cancer as lung cancer, regardless of their site of the metastasis or where the disease progressed. So if you're saying that, brain is different because brain has neurons and neurons are communicating with the tumor cells. Bone is different because bone has different cells, and the liver is different, liver has different cell architecture. And we are using our host immune system to fight against the disease, then we should add another layer of strategy, how to tackle each disease site with the knowledge of the disease progression. So what we believe is eventually this paradigm shift will lead to showing that any kind of cancer that's going to brain has a neuronal crosstalk. What are the drugs do we have in our armamentarium from A or B type of cancer that will help to minimize this crosstalk and make the disease behave as extracranial site as possible? So with this, actually, I'm grateful to say that we were able to convince the same company with this data, with additional resources from the other cancers, now learning from kidney cancer brain metastasis study, zanzalintinib will be tested in breast, lung, melanoma, and even GBM tumors to help us to see that are we able to see any tumor microenvironment change with zanzalintinib in those brain metastasis tissues. And this study is going to be a multi-center study led by my partner in crime, Dr. Merve Hassanov, and our outside collaborator from University of Wisconsin, Dr. Mustafa Bashkaya, who is the neurosurgeon that will be helping to execute this in the multi-center fashion. So what are the conclusions in regards to this study and scientific findings showing that renal cell carcinoma brain metastasis microenvironment is different, is immunosuppressive, is not as easy to treat as other sites of the disease. And one key hallmark of this brain metastasis behaving differently is there's an attack to the neuronal home base, where we think and where we function, and tumors are hijacking that process and allowing them to grow more in that environment through that crosstalk, and which is leading to more immunosuppressive environment. And perhaps this deserves a paradigm shift in all cancer field for managing the brain metastasis. So this is an ambitious goal, and we need really people and everyone in this room to help us to achieve this goal. I'm going to present you the next series of the projects that are evolving near the end phase, and probably within the next couple of months, all of this data will be available in public domains and presented in the national conferences. So this is our current framework for this brain metastasis research. We are collecting tissues from different centers, including Ohio State University, and performing multi-omics studies to identify targets and developing mouse models to test them, collaborating with industry partners to streamline the clinical trial process, because by default, it's a high-risk disease, and it's not easy strategy for them to go after the most challenging manifestation of the disease, where there's a less challenging approach that they can take. And ultimately, the goal is improving the standard of care. So a few lines of work. These are our participating collaborators, along with Orion Network, which provides a large data resource across the 19 centers, where OSU is one of the leading sites of this network. So this was the first study that I described, now led by our PhD student, Mustafa Ismail, and internal medicine resident, Zeynep Akpınar. So this study is soon to be available in more detail. And next, we also performed deep sequencing to identify not the tumor microenvironment related, what makes the kidney cancer cell to get out of the kidney and go to the brain and nowhere else. So what is the genomic-driven defect that make them, that they like to go to brain? So that study was led by our hem-onc fellow, Betül, and bioinformatician team, Pepe and Alessandro. And now the next wave of the research, what I see is going to be dependent on majority of the work on the code. So that's why I put this as a code to clinic, which is going to be implementing the machine learning and AI models. When a patient comes to the clinic, we should be able to say that, what is your risk of developing brain metastasis, how soon we should do the MRI brain, how often we should do MRI brain, and if you develop a brain metastasis, what's the best choice for you, and what is the prognosis out of this? So these algorithms are currently developed, and again, soon will be available by Peng, Zuhair, and Semiha. So KCA is really following the edge of the science, and recently had a very nice workshop about the kidney cancer mouse models. I was not able to attend due to the family reasons, but I'm proud to say that now we have a kidney cancer brain metastasis model. So at this point, what we only need is support, funding to test all these hypotheses in this mouse model, accelerating the clinical trial development. As of now, we have 3 different approaches that we have been taking, and with the goal of hopefully changing this algorithm eventually better, that the standard of care drugs will have more potential, or which standard of care drug will have more potential in treating and preventing brain metastasis. Now, lastly, I want to highlight, if you go back to the clinic on Monday and talk to your physician, what you could advocate for. One is early screening. Even this is an adjuvant treatment starting point or first-time metastatic disease, everyone should have at least one MRI brain. And in my practice, I usually recommend continuing at least once every year, so that we will not forget about the existence of a brain and the potential of that disease to go to the brain. And the second is about brain is a metastasis, but it is the most aggressive metastasis. And it's not only another site of the disease, it's where we think, where we function, where we process all the knowledge. And when it turns out that we develop a brain metastasis, it goes through the challenging process of the surgeries, radiation, with potential complications that is impacting the quality of life. So we should do everything possible to catch it early at asymptomatic stage and hopefully manage with systemic drugs. One must is here is the multidisciplinary management. If your medical oncologist, not talking to the radiation oncologist, urologist, and neurosurgeon, you should encourage them to do that, because otherwise the brain metastasis care is impossible. Now, one small hope is, which we actually started with our brave team here, discussing every patient lesion by lesion with Dr. Raj Singh, is, so the patient has 5 lesions, 4 of them looks dangerous, let's not take a risk, let's radiate them. 1 of them looks okay and maybe small size, and that could be managed with a systemic drug, that we are starting to implement this practice, so that hoping that this will evolve to standard of care upon the findings of the clinical trials. And more importantly, in that regard, whole brain radiation treatment, stay as much as possible away from that. If that will be recommended, make sure that you get that consultation from a high volume center. Obviously, if Dr. Raj Singh and Josh Palmer tells me that, well, there's no point that we can radiate all these lesions, the patient must go and have a whole brain radiation, that's the only way I would agree. Otherwise, even with a large number of brain metastases, we see that the quality of life is much better with stereotactic radiation. And we are always here to help, either with a remote or in person, reach out. And I want to thank a lot of people here. So definitely patients and their families from Turkey, from Emory, from MD Anderson, OSU, and everywhere who has donated their tissues for these studies and volunteering and enrolling in these clinical trials. Pelotonia is really not only the catalyzer of this process. I would say that I wouldn't have been able to imagine this progress in the last 2 years without Pelotonia support that help us to bring talented people to our team and helping to deconvolute this process, deconvolute this challenging disease manifestation. And now we have a biking team. If you want to join us, it's a bike for brain metastasis. So it's a brain metastasis biking, and makes us to think every day on as we push the pedal forward. And this is our laboratory team. I'm so grateful to have these young, talented, smart people working with us. Now I feel like that the problem is not my problem only. As I was on paternity leave, I was impressed how much they have achieved during this time, really committed to the success. Again, KCA for the Young Investigator Award, and SITC and ASCO and other IKCC, where has been helped so far to fund our studies. And I don't want to finish without really acknowledging our colleagues who are helping on day-to-day basis, always available. Our medical oncology folks from our leadership, Dr. Rolfo, Dr. Mortazavi, and urology folks, Dr. Singer. I feel so comfortable to reach out to him and really ask most challenging questions. Is it standard of care or an off-label approach? How we can innovate, how we can make this most feasible approach for this patient at every case. And our brain metastasis collaborators from radiation oncology, neuro-oncology, neurosurgery, and of course our cancer center leadership and Pelotonia leadership. And I would say that I was another excitement hearing that Dr. Ratmill joined our leadership team, and we actually start having some discussions. So looking forward to enriching that, and hopefully this will help us to advance the needle forward and help every patient sitting in this room and outside of this room. Thank you so much.